Yes, the presentation is
Presentation is ready.
Doc.
Yes.
How many presentations?
عندنا 50 virtual. تذكر العدد بقى. For the question will coming.
Okay.
You will write it for me the questions for the Q&A.
Assalamu alaikum. Good afternoon, everyone. It is a great pleasure to welcome all our staff members and distinguished attendees who's here with us in the main auditorium and through our virtual channel to today's scientific talk and clinical session. Thank you all for being here and for your continued commitments to learning and collaboration. We are honored to host our international guest speaker, Dr. Bruce Price, a highly respected neurologist and expert in his field. Dr. Price is the chief of the Department of Neurology at Mecklin Hospital, an associate in neurology at Massachusetts General Hospital, and an associate professor of neurology at Harvard Medical School. Dr. Price will be speaking about traumatic brain injury, focusing on the neurological, psychiatric, and rehabilitation aspect of this important topic. The session will be moderated by Dr. Ayman Kassas, our hospital neurologist. Dr. Ayman worked in Saudi Arabia as a consultant neurologist since 1998. He has very extensive experience in managing patients with different neurological pathology. His main interest in movement disorders and disability. In addition to this, Dr. Ayman has a wide experience in general internal medicine care. Please note that there will be a question and answer session at the end of the lecture, during which you are welcome to ask your question. Thank you all for joining us today, and please join me in welcoming our speakers.
Yes, the floor for you, Dr. Price.
Okay, you want to stay
Show
here?
me
or-
how do I advance my slides?
This one.
Yeah, okay. And which one is that? This is forward, this is,
This is backward.
Backwards
This is
is
forward.
forward.
You want to use the lapel?
yeah, do you have that, please? Yeah. This. Is that fitting? Yeah, there you have to clip it. Yeah. And I can put this on my pocket, right? And forward, backwards. Okay. Thank you, thank you. So, hello. Thank you for inviting me. My first comment would be I would like to give tribute to Prince Sultan. I mean, what a remarkable institution. I had a glorious 3 hours making rounds, seeing a few patients, and my mission is to teach a bit, but also to learn from you. And I would consider this institution amongst the world's top rehabilitation hospitals, and I mean that from the United States point as well as the world point, in which I've traveled extensively. So it's a remarkable honor, it's a remarkable privilege, and I'm giving several lectures, but let me start with traumatic brain injury, usually moderate to severe, and the neuropsychiatric sequelae. And if this works, oh, that's right. It doesn't slide here, but I can look here. Yeah. So it's, there, good. Yes, so I would like to start with a very personal family story, tragedy. This is my daughter on the right. This is her husband, Michael Albarelli, on the left, and this is their two children in 2017. Oh, the podium list, that's fantastic. Wow, wow. In 2017, unfortunately, the gentleman on the left, my former son-in-law, for reasons we still don't understand, fell down 14 steps from his kitchen into the garage, onto the concrete floor, and suffered a severe traumatic brain injury. Unfortunately, his children at that time found him unconscious on the garage floor. They're now, I think, 11 and 13. We don't know what consequence that might be. Is that a trauma? Is that a memory on these children? He was admitted to a hospital in New Jersey, massive head injury. We did all things modern and scientific to reduce the edema, to reduce the recurring hemorrhages. And for the first week, we really tried to resuscitate him, save him, rescue him, hopefully live for rehab in a campus like this. Unfortunately, things got worse over the first week. The second week we spent with the ethical, moral question, if you will, of what do we do? What would he have wanted? What would his parents have wanted? He was the elder son of two, ran a family business. And the interesting thing is that he had a younger brother who kind of helped us with a dilemma. He said he had a conversation with him a month before this happened, and that Michael Albarelli would never, ever have wanted to live this semi-vegetative life. So the tough decision was we transferred him after 2 weeks to palliative care, withdrew life support, and within 3 hours, he had passed peacefully. So I know traumatic brain injury from a deeply personal family point of view. 2017. So let's go on to the initial damage. This is a paper published in 1937, 40 patients autopsied, and we understand acceleration, deceleration, rotational forces centered on the midbrain and thalamus, which gives you the impaired consciousness. And the next slide is actually, one major point is neuroanatomy is foundational. It is distributed neural systems that comprise of anatomic regions, or nodal regions as we call them, unique in its architectural property, geographically arranged throughout cortical and subcortical areas with remarkable connections downstream and upstream, and linked anatomically in a very, very precise and unique manner. Again, this is the ideal brain, but these are the average and ideal circuitry. On the left, a number of years ago, in the middle, one of my mentors at Harvard, Marcel Mesallam, and his colored version of the brain and its regions, and a more recent modern construction of the brain as it stands now. And this is another study, 1937, 40 cases, brain autopsy. So it shows you where the damage happens, the deceleration, the acceleration, the rotational forces. And here are the post-traumatic brain injury, moderate to severe, signs and symptoms in the neuropsychiatric realm. So in the frontal network lesions, you see diminished initiation. In my country, we would call that amotivational state. Decreased interpersonal interactions. They're not the same person by personality, if you will, that they change dramatically. Passive, again, amotivated, mentally inflexible, unable to quickly change sets of thoughts, and perseveration, unable to lose a thought, and the thought drives them beyond what was normal capacity. Orbital frontal lesions, disinhibition, dysregulation of mood, anger, impulsivities, things that you see, I'm sure, here daily. Sexually, socially inappropriate behaviors. Again, they have changed. And then the temporal lobe lesions, memory at all levels. So in memory, we look at that as encoding, storing, and retrieval. Emotional expressiveness, uncontrolled rages, mood, crying, laughing. See that rarely, but you do see that. Mania, delusions, so-called psychotic features. And psychosis, by my definition, is the gross alteration of perception of reality. And these are the complexities I see, the clinical complexities. Are these neuropsychiatric consequences of traumatic brain injury due to the direct injury of the brain? Could they be secondary to emotional stress and maladjustment, the social disruption of your normal life? And or associated with symptoms such as pain, vertigo, headache, and sleep disorders. So these are things we have to deal with diagnostically and therapeutically. And is it the direct attribution of that brain injury, or were there pre-existing factors? Depression, anxiety, post-traumatic stress disorder, personality conduct disorders, ADHD, substance abuse. In the United States, alcohol and steroids are unfortunately abundant, and poor general pre-injury health. Associated injuries, as we've said, orthopedic, chronic pain, life stressors, employment status, exaggeration or malingering, protracted litigation. So I don't know in Saudi Arabia, but in the States, there's a lot of liability issues. Who caused what accident? What is the outcome? What will the outcome look like? And it is a billion-dollar business. And sometimes we in science need to jump in and try to give us the best science, and the judge and the jury the best science of what we know to be facts to help render the decision. And then prior traumatic brain injury. So at least in the States, it's not kind of the normal population that is most prone to brain injuries. It's those with high risk. So motorcycles, reckless driving, and on and on. So this is not the normal population, but the high-risk population to begin with. And again, post-traumatic brain injury, genetic predispositions, many I think of which are unknown at this point, and the apolipoprotein E4 status. So in the United States, this is primarily focused a little bit on post-concussion, so not severe or moderate traumatic brain injury. So you should know that 100,000 to 600,000 patients in the United States per year sustain brain injuries with loss of consciousness. 35% of these are seen in emergency rooms, 25% are hospitalized, 14% are seen in doctor's office or clinics, and 25%, particularly in the post-concussive syndrome, seek no medical care whatsoever. So therefore, these studies are often based on non-representative samples, again, high-risk people more than not, with high attrition rates in these studies, and inclusion in post-concussive syndrome, even if they endorse a single symptom, such as headache or diminished concentration. So it's messy. We have to sort out what's happening in a more rigorous fashion. Additional variables, gender, male, female. We don't, at least in my experience and knowledge base, haven't studied that question very much. Race, is that a predisposition either in favor or in disfavor? Socioeconomic status, pre-existing the injury, employment status, the social disruption after brain trauma, additional physical symptoms, pain, headache, dizziness, and litigation, as I mentioned, which is an industry, if you will, in which, in the United States, it's a It's the plaintiff versus the defense. And let's say a construction worker is injured, who's at fault? And that becomes a big courtroom issue. And if so, and if, say, the construction company is, at what extent are they liable? At what extent will the patient recover? At what extent will they need financial support for the rest of their lives? And medications, which we will talk about. And as we made some rounds on 2 or 3 patients this morning, and one of my things is to, particularly when they come in what we call polypharmacy, so 6, 8, 10 medicines, and when you visit different doctors and different diagnoses and different medications, but there's no person that oversees. And one of the best treatments I give is to minimize medications, withdraw medications. A lot of adverse neurotoxic side effects that we don't pay much attention to. And this, again, mainly is post-concussion syndrome. And behavioral and cognitive impairments may be present despite the absence of abnormalities on imaging, less so in moderate and severe severe MRI, CT scan abnormalities. Current imaging is unable to date the acquisition time of abnormalities, and by that I mean you see the flare, the hyperintensity, without a prior MRI scan study. We can't date, that's happened on the date of the head trauma. So we have no dating possibilities to this day, and hopefully not in the future, to say when did the patient acquire that particular brain imaging abnormality. And there's a wide spectrum of normal variability within neurologic findings. A imaging abnormality does not predict or necessarily imply dysfunction of the area. Years ago, we did a volumetric study on prefrontal cortex amongst students in Boston, and found that the variability in volume, the variability in configuration of even the prefrontal cortex was incredibly heterogeneous and variable. So these are all very complicating factors. So what needs to be done? In my world, dreaming as I do often, we need to align study methods to include accepted, validated nosology with appropriate inclusion and exclusion criteria across multiple institutions, multiple disciplines, and multiple countries. And that's why one of the missions that I'm here for is, can we all gather a world council and look at all these in the same way? So again, uniform ascertainment methods, and can we define surveillance periods with sufficient time course? What I would like to see is longitudinal studies 3, 5, 10, 20 years later to see what we gain and how can we sharpen our prognostic predictions. We saw a patient today, 18-year-old gentleman, traumatic brain injury, 3 months ago, making some improvement. But who will this person be? What will they be like? What will their deficits be like? What will the recovery pattern be like 3, 5, 10, even 20 years later? That, I think, is the way that we can better answer some of these questions. Continued, long-term, longitudinal, multidisciplinary, multi-institutional studies with precise clinical characterization, close follow-up, and detailed autopsies are needed. Now, autopsies is also, in the faith in which I was raised, the Christian faith, autopsies is not, there's no major objection, particularly when you want to find out what precisely the diagnosis was. And in at least the United States, we're wrong on autopsy study of even the diagnosis in about 30% of patients. In about 30 or 40%, we have incidental findings. And again, in the world of autopsies, neurologists are called in to ascertain prognosis, brain death, vegetative states, et cetera. So acceptable, but still actually not done a lot. Why? One is there's a concern, when you're talking about someone that they have led their life and hopefully well and will not survive. There's a lot of family consternation, and if you don't get the entire family to agree on this autopsy, it can actually splinter the family. So the neurologists, we are the one that usually performs the exam, and we have to get better, I think, at explaining prognosis to the family, and it's a crucial, difficult discussion, again, like I personally experienced with my former son-in-law, who had died, by the way, that he was 38, and at the peak of his career. So it's hard, and neurologists tend to do that, and we have to do that with great empathy, as if it were one of our own, and what would we do? We need to, when there's multiple disciplines, so the multiple disciplines I think would be neurology, psychiatry, rehabilitation, medicine, and we need to get the best of the best of the best of the cream of the crop, if you will, of medical students interested in devoting their careers so that we can carry off this rather magnificent, huge, multi-complex issue. Is traumatic brain injury, that's a mistake, it's TBI, risk factors for the development of depression, mild cognitive impairment, and dementia. So again, taking you back to litigation in the United States, some of the arguments for the plaintiff would be that he's had his head injury, and now with that, in 10, 15, 20, 34 years from now, is the frequency, the prevalence of dementia in his future? There's not a lot of great evidence in this, but here's the evidence as this is, let me do this. This is the intervention. This would be the acute intervention of primary pathophysiology of TBI, excessive release of excitatory amino acids, ionic shifts, generation of free radicals, impaired homeostasis, energy metabolism, decreased cerebral blood flow, release of inflammatory cytokines, apoptosis, death cell, and axonal injury. Can we find ways of shifting these towards a more favorable prognosis? And to my knowledge, nothing in the basic science world informs us much at this point about what we can do in the emergent situation. The link between traumatic brain injury and Alzheimer's disease is controversial, and let me just walk you through a little bit of that controversy. So there's something called the neurofilament light protein, NFL, and glial fibrillary acidic protein, GFAP, but not total tau, which is one of the abnormal folded proteins in Alzheimer's type dementia, were significantly elevated compared with controls. This neurofilament light protein remained elevated after 3 months. Experimental and human TBI. In all of these animal models and human models, the spinal fluid has increased amyloid beta peptide, again, another biomarker for Alzheimer's disease, and tau, another marker for Alzheimer's disease, even in younger patients. Repeated mild TBI in both animals and humans accelerate amyloid beta peptide accumulation and cognitive impairment, and the prognostic influence of apoprotein lipoprotein E4 genotype and other genetic factors remain under investigation. So I'm involved a bit in Boston University. They're kind of the leaders in this concept of chronic traumatic encephalopathy. And by the way, this is what my former son-in-law, we did do an autopsy study because we were interested. His brain was examined at Boston University, and he came up with a diagnosis of grade 1/4 for chronic traumatic encephalopathy. What that means is a little uncertain. It's a very controversial field. There's something in there about repeated head strikes over time. We study National Football League, as in American football, concussions, hockey players, all these aggressive, high-impact sports. And there is something there. We tried looking at the tau protein in PET scans. It really didn't give us in vivo evidence. It remains a neuroanatomic pathologic diagnosis, and we don't yet know how to intervene and treat that. So I'm involved in that world. It's an interesting world, and we will see how the scientific discovery plays out there. So in my review, giving this lecture, I went back and found this INCOG 2023 2.0 guideline, Journal of Head Trauma Rehabilitation 2023. Looking back, this was their update after their original publication of the guidelines in 2014. So 9 years later, with some new recommendations. And again, regarded only those with moderate to severe traumatic brain injury. And the affiliated authors were from multiple academic sites in Canada and in Australia. So as a very, very quick review of what I thought was new, would be the general recommendations. And again, making rounds here at the Humanitarian City, I think you hit the high notes on really virtually all of these general recommendations. So individuals should be assessed for appropriate interventions by trained clinicians, a quiet, safe, consistent environment, avoiding overstimulation, minimizing the use of physical restraints, which we try to do in the world of psychiatry very much with good success, but not always. Sometimes you absolutely need physical restraints, hopefully as a temporary measure. Facilitate light sleep, daytime wakefulness is tolerated, and one could do that with different sleep habits and circadian rhythms. Physical therapy, standard activities of daily living principles can be effective and should be tailored to the patient's symptoms. We need to identify and address triggers for major behavioral symptoms. Triggers being noise, triggers being obviously infections, triggers being certain family members that irritate versus calm. So there's a lot of psychological interventions that we always need to be aware of. The use of neuroleptic medications. One of the patients, I think, was on risperidone as a transient treatment for agitation. Benzodiazepines, the Valiums of the world for agitation, should be minimized and monitored using standard. So in my experience, sometimes these patients are put on these medicines, but the thought is never to take them off. And again, that's one of the conquests that I like to do, is let's take off the medicines and see if they clear in terms of their confusion, for instance. Provide frequent reassurance, which we did, hopefully, with some success today to the patient and their families. To evaluate the impact of visitors and to help family members understand traumatic brain injury and how best to engage and minimize triggers. It's a family disorder. It's a shared disorder. There's one victim, if you will, but the social and economic downstream effects must be addressed. So those are general recommendations from the 2023 guidelines. So now I'm going to take you through the subsets of neuropsychiatric sequelae. And what I teach and what I understand through my experience is attention is the foundation for cognitive functions. If you're inattentive, then you can't remember, because memory involves encoding, storage, and retrieving. If you don't have the intentional mechanism to encode, then of course you're going to be amnestic. And by the way, what I do on the bedside when I teach at Mass General and at McLean Hospital is my brief, now these are screens, are to ask the patient to spell earth. If they do that, then ask them to spell it backwards. And if that is accomplished, then to alphabetize. So you're going into attention, concentration, and verbal working memory. And those are the bedside tests that I use. Because attentional problems include, by the way, you have to go through the differential diagnosis: hearing, vision, fatigue, sleep-wake, anxiety, depression, pain, substance abuse, and medications. All of those can manifest in what in neurology we call subacute or acute confusional states. In psychiatry, at least in the United States, what is called delirium. Back to the INCOG 2023, there's a lack of computer-based attentional tasks and insufficient evidence to support mindfulness-based meditation, periodic learning, or non-invasive stimulation. Methylphenidate, in the States it's branded as Ritalin or Adderall, is recommended to improve information processing speed. You have to go slow, titrate upwards, and make sure there's no adverse neurotoxic side effects. Methylphenidate can have an impact, for instance, on dopamine. And by the way, there's no clean, precise drug, in my knowledge, that hits only one target. There's a lot of downstream. So we call them dirty drugs because they're not so well specific and targeted as to hit just the one thing we were thinking about. And amantadine, in the States called Namenda, or another one called modafinil, all psychostimulants, may facilitate arousal in comatose or vegetative patients. In my practice, or our practice in the United States, we actually give those not only if they're comatose or vegetative, but they need to be stimulated to focus their concentration, attention, encoding, and retrieval, with some side effects which need to be monitored closely, but worth the risk in most patients that I've encountered. After attention, to me, second most important in terms of rehab recovery is what we call executive functions. I define that as impaired insight, awareness, concern, ability to make complex decisions. Here they listed as impairments in emotional regulation, disability, and by the way, you should know that there is an elevated suicide and violent crime risk in those that do even recover, but not entirely. Their key points: no current level C, which means it has to be duplicated by different laboratories, or greater evidence for music, dance, yoga therapy, although that all feels good. And sometimes you can take these people on museum tours or amusement rides, and at least temporarily buoys their motivation, their attention, but that's short-lived. Some evidence suggests benefits of cerebrolysin, which is a neuropeptide, not approved in the United States, Canada, or Australia because of adverse side effects, and more research should be done. What about subacute transcranial direct current stimulation? Should not be used outside of clinical research to date until proven otherwise. And in those that have pituitary dysfunction, the use of recombinant human growth hormone is now being done in the context of research trials, but is not generally recommended if it's not a research trial, and that there is insufficient evidence to support neurofeedback for moderate to severe TBI. Communication, social cognition, what I call the social brain. New evidence to support treatment of cognitive communication disorders, particularly social interactions, communication partner training, group treatment to improve social communications and telehealth delivery. Further outcome in the research world is needed. But the social, what I would call comportmental aspects of brain function are incredibly disabling. How to initiate a conversation, how to sustain a conversation, how to have meaningful engagement between you and whoever's communicating you're with, are very difficult to entrain and recover after a severe traumatic brain injury. Again, outcome research is needed, but just the use of groups, of families, of friends, if you will, trying to learn back the communication skills looks to be promising. So in the old world of aphasia, which is the way I came into neurology, we used to make rounds in what's called the Veterans Administration, and this is where there would be group patients all together, say 12 patients, veterans, and the social communication and the encouragement amongst themselves we thought was actually very, very, very therapeutic. So treatment should be culturally responsive, obviously, and if I may take off on that a bit, it's interesting in my field, and probably even in the fields of psychiatry and other fields, that we don't ask a central question, which is, what is your faith? What is your hope? What's your belief system? Because that's incredibly important, probably the one thing that guides you in your beliefs the most ever. But for some reason, I try to train residents and fellows ask the question because it's so relevant to who they are and what they identify with, and to take into account the person's pre-morbid physical, psychosocial variables. And consistent, well-trained caregivers should be employed. Then finally, if your attention, if your motivation, executive functions, if your social brain is recovering, then we come to the memory and post-traumatic amnesia. And as you know, it still looks to be useful to do the time of the head trauma, what they have forgotten before the head trauma, what they have forgotten after the head trauma, as a way of grossly at least judging the severity of the brain injury, and I think that still holds. Rehabilitation goals should be developed to realize, really you have to focus what's meaningful to the patient, what's practical to the patient and their families. Computer cognitive training looks to be helpful. Strategies such as mobile smartphones, notebooks, whiteboards, as we call them, the stickies. You write that little note and put it on your refrigerator as reminders, are useful. Individuals and their caregivers should be trained in how to use these strategies. And here's significant barriers, particularly in less developed countries and with the socioeconomic gaps. Who can get access and affordability, portability, and reliability for these cell phones? That's clearly a barrier, at least in the United States, for sure. Cognitive skills training across all levels of memory impairment should be strategy-focused and conducted by an experienced therapist. So what I mean by that is, again, I divide attention into three mechanisms. One is concentration, two is storing the information, and three is the ability to recall the information at a later date. And there are strategies that can be used by an experienced therapist, and there is no evidence that group-based interventions are more effective than individually oriented rehabilitation. So that means to me that you can do this through groups, you can do this individually. Again, emphasizing mobile, smartphones, Zooms, have improved the choices for compensatory strategies. For those people who are older and computer adverse, the good old-fashioned use of paper and pencil reminders can be helpful. And although there is limited evidence to support the use of acetylcholinesterase inhibitors, those are the ones we use and with some effect, modest effect in Alzheimer type dementia, may improve memory. It may be considered for adults with TBI who have chronic deficits in memory. And there's a colleague and fellow of mine named David Arciniegas, a professor at the University of Colorado, Denver, who would dispute that and say that there is a trial of acetylcholinesterase inhibitors should be tried in anyone 1 to 3 months out with still impaired consolidation of memory and recall. The final two things that this NCOG group mentions is transcranial direct current stimulation should not be used to improve memory outside of clinical trials. There's not enough evidence at this point. And limited evidence exists to suggest that methylphenidate and amantadine improve memory. I tend to try those. They're fairly innocuous. They don't have a lot of cross interactions with other drugs, and I think they're worth an empirical trial, monitoring closely to see if they in fact have shown you benefits or not. So the first picture of my family I showed you was in 2017. This is now 2025. So the good news is that life does move on despite the tragedy of a death. The good news for my daughter, second from your left, Shannon is her name, is that she found a husband on the right who also lost his wife. He brought in 3 older boys. Those are the 2 younger boys you saw on the doorsteps in the lower left. So William, Peter, and Samuel Alvarelli. So despite tragedy, life goes on as it must, and you can eventually settle and find something that gives you hope. And so now my daughter Shannon and her husband Lee share 5 boys and actually have blended the family incredibly well. So even the oldest boy at 21 loves to play with the 11-year-old. They love sports, they play football, they ski, and it truly is a successfully blended family. And so this short lecture really, I hope, provokes thoughts. I hope promotes exchange of ideas, even open and civil debates. I'm here really to learn from this experience, as I've learned from the rounds that I made this morning, with the idea that we need to push discovery further. This was in India when I was there a few years ago on a mission, and if you can read that was in one of these temples, and it says, "Mind your head," and that would be the end of this particular lecture, and thank you for your attention.
Thank you,
Yeah, please,
Professor
come up.
Price, for this interesting lecture.
Whoa.
I think we might take questions after this lecture, and then we will go to the second presentation. So the floor is open for question and
I think I'll
discussion.
leave this. Yeah. Whoa. So please, what I say about science that I like is no paradox, no progress. Controversy fuels us, pushes us forward. So I would encourage anyone in the audience to ask a question. Do you want to call on people? Or yeah, maybe this one works then. Did it? I think they restored that one, no?
Thank you, Ayman. Thank you, Pras.
Yeah.
Very interesting lectures. You speak about the sequelae of traumatic brain injury. Now, my question is not going to the long term. In the acute status, with the current intervention in the guidelines, like hypothermia and induced coma, do you think that those things, and controlling the blood pressure to normal, are they having any effect in the long term? Since there is also some debate about them and leaving the brain to react at its want to heal. So what is your view in this situation and the long term?
Right. Did I hear the word hypothermia as a treatment? Yeah, yeah, yeah. So that's been studied, and there's lots of paradoxical results. Yes, no, no difference whatsoever. That's been looked at, for different causes, hyperbaric chamber, and this particularly regards cardiac arrest and hypoxic damage to the brain, and what can we do to restore. None of those have been convincing, compelling evidence so that it's changed the standard treatment in acute head trauma to my knowledge. Now, other people may have different experience and different knowledge base, but to my knowledge, at least at Massachusetts General Hospital, that is not being used. Although when you have some patients with stroke, sometimes they do give hypothermic treatment, trying to reduce all of the primary pathologies of cardiac arrest, brain hypoxia.
Agree with you, it's still controversial. My question, the second question,
Yes.
do you think the current practice, because induced hypothermia, induced coma, and etc., and either hypertension or hypotension are still a practice in traumatic head injury?
Yeah.
Do you think that those protocols play a prognostic factor in the future for survival of traumatic brain injury?
Right. So restate the question one more time so I can focus on the answer.
Okay, focus. Now, the current guideline
Yeah,
are controversial,
yes,
inducing hypothermia,
yeah,
as you mentioned, coma, and controlling the electrolytes and blood pressure, and some people aim to higher.
yeah.
Do you think that those practice carry any prognostic factors
Yeah.
for the prognosis of patient in the future?
Right. So the new standards, at least by the American Heart Association, has redefined hypertension, one of the major causes of stroke. I think the ideal now is it should be below 130 and certainly below 80. And it does look to be that the incidence of stroke, at least in the United States, has been measurably diminished, really with the control better of diabetes, hypertension, hyperlipidemia. So those are all important factors, which I'll talk about, I think, tomorrow when I lecture on successful aging, reducing dementia risks, and dementia care. In terms of acute management, and again, I'm not in the neuro-IC intensive care unit world, but there used to be that some people would continue to perfuse with high blood pressures, systolic blood pressures. Some people would think, no, you have to lower the blood pressure to prevent further damage. I don't think at Mass General either of those are practiced anymore. They simply, good ideas, but sometimes good ideas don't make science and don't make facts, evidence, truths. So what do they do when someone comes in with an acute stroke? Really control their blood pressure, but not too high, not too low, perfuse well. Look for the cause underlying, do the studies if you need the angiograms, look at the artery system to see if we can now lyse new lesions and open up and perfuse that part of the brain. Very important gains in the acute treatment. And those are major urban hospitals. There's a big disparity and a big problem we have in the United States with rural care. And I assume you may have that as well. Because if you're supposed to give these lysine agents within the first 24 to 36 hours, you have a hard time if you're isolated, let's say, in the middle of this country to get that kind of care. In particular, though, that can be incredibly helpful, and there have been people that have been lysed, no blockage exists, with perfect recovery afterwards. So to me, those are the new innovations in stroke therapy.
Yes, Dr. Iman. Dr. Inas, yes. Ahmed.
Thank you, Dr. Bruce, for this interesting lecture. I was lucky this morning to have the clinical implication of this lecture on our patients for your consultation. Actually, in the rehab field, we have psychological and emotional consequences of traumatic brain injury on the family members or the caregiver. So, is there any like strategy or something that we can manage the caregiver or the families to cope with their beloved patients who had suffered from traumatic brain injury or stroke or any brain involvement, that you can give us an idea about that?
So I hope you saw that we worked with this team and perhaps left a family more informed.
I mean the caregiver for the patient
Caregiver,
who has
exactly.
traumatic brain injury.
Yeah,
Yes.
exactly. So let me take this patient that we saw, who shall remain anonymous, but here this morning, 18-year-old, car injury, severe traumatic brain injury, and 3 months out. And the father was there. And then the very good rehab team that we met, we saw the patient, met outside, then went in and informed the father. And we went outside because you just don't know, even in this, it wasn't a vegetative, but it was an agitated state, whether he comprehended anything or not. And by the way, this is, I think, the way discussion should happen outside of the patient's room, because, well, let me go in a tangent here. Interesting work primarily out of Cornell at New York, that even people who we thought were in vegetative states, actually using functional MRI scans, would react appropriately with the right areas of the brain, the mesiotemporal structures lighting up when the name mom was mentioned, or even in certain patients when a sport was mentioned. So it becomes an ethical question. Is that enough to use intensive therapy over years and at great cost? And what is the prognostic significance of that? In this case, it was an 18-year-old fellow, previously in good health, who really had a severe traumatic brain injury, 3 months out, seemed to be recovering slightly. And we informed the father that maybe there were some medication changes that could be beneficial, though that's very much trial and error. I think I spoke truthfully about this as one of the best places that patient could be, literally in the world, not just the Middle East, but the world. And I have a comparison with the Spaulding Rehabilitation Institute, which is affiliated with Massachusetts General Hospital, where they do care. And I think this patient could receive no better care than here in Riyadh. Thirdly, we told him that time is the friend. Time will tell. He could be very different and very recovered in the next 6 to 9 months. It's too early. And that, there's hope. There's belief. There's faith that he can get better. So you tell me, but hopefully we left the parent. And I don't know if the patient heard that or not, but the patients also need to hear frequent reassurance that you're doing better. Congratulations, work hard. But I think we left that situation a little bit different and a little bit more hopeful than when we entered the room.
Thank you, Dr. Rice, for the interesting lecture. And we have very interesting program, as you have said here, for rehabilitation. And most of the injuries that come to us is post-car accidents, brain injury. But speaking about the types that you have mentioned for a brain injury that could happen from different reasons, have there any studies done through your experience from those kids or young ages who are seeing social media, which they call it the new term brain rot? Brain rot, have you heard of this? And I think, I don't know if there is any studies done recently about this, and how is the effect that might be expected on the coming years? Because I think it's common among all young ages. Are we expecting more brain injuries symptoms to happen in the world? Because it's across the whole world. And what's the advices if this will happen? Yeah.
Right. Fair question. Good question. The earlier the intervention, we think, the better the outcome. That's a general rule in medicine. Like, for instance, I do a lot of research and study with dementia. We think that the earlier we can pick up that there's an insidious progressive memory loss, the earlier we can intervene with modest medications at this point. We don't have cures necessarily or preventions right now. But I would think and I assume, are you talking about the pediatric population in general or the adult population? I mean, the first thing you do is you prevent, you encourage, I encourage at least helmets when you're riding bicycles, seatbelts when you're riding cars. That's the real prevention. You know, we worry about those people in my country who have substance abuse. You know, the dilemma of alcohol, the dilemma of any street, marijuana, the cocaine. You hopefully don't have the measure of that here, but these are all prevention. And you know, anymore neurology is used to we would wait till the catastrophe happens, and then have very few instruments to correct the course. And now we look at preventive neurology. And I will talk about that when I talk about successful aging, I believe tomorrow. So really the future, I think, is in prevention and not after the catastrophe has happened. Does that help, or please ask more?
Yes, my question, so far until now, there is no kind of studies done on similar brain of young people. So far, from your experience?
Yeah, in traumatic brain injury, are you specifically saying?
For those people, young ages,
Yeah.
who might suffer from those kind of brain effects of social media,
Yeah. I see, of social media, aha.
Yes, the brain rot. Have you heard of
This is not
term?
related
Okay,
to
I see the brain
oral
rot.
lecture.
Okay. I think I get it, the
Yes,
social
maybe
media
that's
impact.
why it was missing.
Right. So I have 5 grandchildren, so I'm interested in this subject. One of the big controversies in my country is when do you give children cell phones? When you connect them to social media, how do you protect them from that? I think that cell phones are basically, I'm worried about their effect on people and their effect on friendships. There's a person who I know who wrote a book, MIT professor, it's called Alone Together. And there's a famous cartoon on the front of an American news journal paper, and it has a Thanksgiving dinner, which in the United States is the family time to come and talk and celebrate and laugh. And the poster has everyone sitting next to the turkey and what we always serve, but everyone on their cell phone. So no one's talking. And the friendships that you think you have with friendships around the world, I don't think have the real substance. And so what are we teaching our kids in terms of social skills, in terms of attachment? So I'm on the worried side of life, knowing that it's inevitable, probably, that there will be and by the way, it's also linked a bit to depression and anxiety. So are we creating new problems for ourselves? Social isolation, I think, is a real problem. Loneliness in the United States is a huge problem. Lack of intergenerational connection. This is where I think Saudi society, if I understand it, you know, you have intergenerational households. children, parents, grandchildren. I think that's really a lovely thing indeed that we've lost in this country, in the United States, for this. So I think it's arresting social development more than enabling social development. So I count me amongst the worried with our children and what values we're teaching.
Was there any images done on their brain?
Yeah.
Any studies?
For the sake of time, please, but we need to just only one last question.
We can talk
because
afterwards
we
if you
have to
like,
go
yeah.
to the second later on after the second presentation. If there is remaining questions, we can keep it to the end of the next presentation. Please.
One very quick question. Basically, I just want to talk about the CTE, and then you mentioned about the autopsies and then how and when they are practiced, and then that brought me to the work of Dr. Bennett Omalu. How impactful is still his work, and then the guidelines?
Repeat the question again so I can fully grasp.
The CTE.
Yes, CTE.
The work of Dr. Bennett Omalu in 2002, and then the famous movie Concussion.
Oh, concussion.
Because he brought the diagnosis.
Right, right.
Yeah, I'm asking how impactful is still his work.
Yeah. Right, so I am affiliated and have written a few articles with the Boston University, which is the really center of research in CTE. And we know that repeated concussive head injuries, in particular without full recovery from the prior, has an accumulative effect. We know that CTE is primarily a tau, as we say, a tauopathy. We know that an anti-tau antibody trial has been studied and has not shown a remarkable difference. So we don't have an intervention that seems to be effective. We know that it still is a post-mortem diagnosis that we cannot make an in vivo, and we see a lot of people that have had 4 or 5 concussions and they're worried. Does this mean they're headed for Alzheimer's disease, or is this headed for CTE and so forth? We're mainly reassuring that most of them don't, that they're worrying too much, that they should dismiss this. But there's there's the outliers. So we have some confidence in 90%. What about those 10% that for some reason we still don't understand are vulnerable? And what do we say about them other than please don't take more risks? And if you do, please use protective equipment. So we're left with a bit of a unsatisfying mystery. Stay tuned.
Thank you very much. Thank you. Can we go to the second presentation, please? It will be the second presentation. There will be a case presentation, will be given by Professor Price.
I still have my hooked up.
So the second presentation today will be on behavioral neurology. So
You want the next?
the floor is yours,
Yeah, here's
Doctor.
the title.
Okay.
So, rehabilitation medicine, behavioral neurology, neuropsychiatry, where do we go from here? Oh, this is, ma'am, this doesn't work, the slides don't work here, but I have to look up to the screen. Can you help me with that? But now I can face you and not the slide set. So that's the title, and just to honor, if you will, the complexity of the human brain, 170 billion cells, 3,300 cell types, 16,000 genes turned on and off in different combinations. 98 to 99% of our DNA is identical to that of gorillas and chimpanzees, so that's that humble 1 or 2% that we think make a huge difference. On average, 6,000 thoughts, 3,000 decisions, small or large, occur per day in our minds. And finally, the neuroplasticity, epigenetics, which we'll talk about more, demonstrate promise regarding brain modification, as do previously mentioned the gut-brain microbiome, which actually, by the way, over a lunchtime discussion, it looks like breakthroughs are being made actually in autism. That autism, when you look at their bowel, is massively inflammatory, is massively leaking, and there is these neuropeptide communication between gut and brain. So that's a promise for autism, perhaps. It's a promise, as we discussed, for Parkinson's disease, perhaps. So it's a great time to be in science, and particularly in neuroscience. The next two slides are why is science so important? Because I feel in the United States, and really most sections of the world, science is actually under attack. And so this is my attempt to address why science is so important. To me, science is agnostic and universal. It has its own demands, regardless of country, probably regardless of faith, that evidence, facts, and evolving truths, in fact, do exist, that there are few simple explanations in science, and that research can be misperceived by the public as an endless cauldron of turmoil, doubts, uncertainties. Yet these qualities are essential to this discovery process, which can be slow, no doubt. One of my favorite sayings in science is no paradox, no controversy, no debate, then no progress can be made. Research represents the rare balance between imagination and critical thinking that tells us whether a good story rises to truth or not. And, quote, the slaying of a beautiful hypothesis by ugly facts, end of quote, is part of the scientific method. And I've been slayed many times with clever ideas, I thought, but then the ugly facts would dispute them. And why is science so important? And I've just carved out different perspectives. So there's a very famous astrophysicist named Neil deGrasse Tyson, director of the Hayden Planetarium at the American Museum of Natural History in New York City. Quote, the good thing about science is that it's true whether or not you believe in it, because it stands alone, agnostic, universal. From someone I don't know, but from my institution, the Nobel laureate in medicine and physiology, Professor Gary Ruvkun, quote, discovery of the surprises is what keeps you young in science, and I'm constantly surprised. My ignorance is bliss. Next, from a professor of physics at University of California, Santa Barbara, Professor Caitlin Casey, quote, the best science is done when everyone thinks about the same data set separately. So debate, convergence, agreement, we move forward. And a quote from a patient, which I think is remarkably important with recurrent cancers. Quote, what new discoveries mean to me is that they can kick the can down the road for 6 months, then you hope that new discoveries will kick the can down the road another 6 months. Hope is essential. So let me describe to this audience what is neuropsychiatry, what is behavioral neurology. three basic definitions. The multidimensional study of brain, cognitive, affective, and behavioral relations, including arousal, engagement, motivation, reward, perception, memory, language, emotional processing, and social cognition, all which go back to the lecture I just delivered. All of these functions, neuropsychiatry, behavioral neurology, likes to study, tries to see discovery, pattern recognition as we call it. Second definition, neuropsychiatry, behavioral neurology, the exploration of diagnostic and treatment options in neurologic diseases with comorbid cognitive, behavioral, and psychiatric symptoms. All of these things merge into TBI. And third, the investigation of brain circuits involved in mood, anxiety, psychosis, post-traumatic stress disorder, stress itself, sleep, obsessive-compulsive disorders, addictions, and somatoform disorders. So it's a natural blend, I think, between neuropsychiatry, behavioral neurology, and rehabilitation medicine. So very quickly, a sweep over the last 60 to 100 years on how neurology and psychiatry are actually converging. A quote from a 1997 manuscript by Professor Jaspers: "Studies of the brain and the mind are like the exploration of an unknown continent from opposite directions, where the explorers never meet because of the impenetrable country that intervenes." My academic mission over the last 40 years has been to converge neurology, psychiatry, and now I would like to invite the convergence with that of rehabilitation medicines, since we share such a common ground, common goal, common desire to heal. Then a quote from, I was the first author with my mentor, Raymond D. Adams at Mass General, Neurology and Psychiatry Closing the Great Divide, because there's been mind here and brain here and nothing in between. We're trying to merge, integrate more than ever. Another quote from an article I was a co-author of, the accelerating growth of research in neuroscience, behavioral sciences, and epigenetics will likely make substantive inroads into this complex territory. And just a brief comment about epigenetics, that is the environmental forces that can change the very nature of RNA and therefore DNA. Some interesting studies have come out that parents, mother or father, but primarily mother, who have PTSD, so some post-traumatic incident that has been irrecoverable and or inescapable until treatment, flashbacks, startle responses, you know about PTSD. In the following generation and the following generation after that, there's a higher incidence of anxiety and depression. So there's some kind of transmission going on with PTSD through multiple generations. And then the next quote is, the accelerating growth of research in neuroscience will likely make substantive inroads into this complex territory. Again, another quote from a journal article that we published. And let's see, there we go. And then the final quote, rather than further contracting into separate fields, the convergence of neurology and psychiatry, also rehabilitation medicine, should span the unique intersections of humanity, philosophy, and science. So we're philosophers. We're scientists. We're humanitarian. We want to heal. So it's a wonderful club to be in. A gentleman here, I think, who got some of his training at the Salpêtrière. This is a quote by Jean-Martin Charcot at the Salpêtrière in Paris. And he's reminding us 100 years later, well, 50, 60, 100 plus years later, in the last analysis, we see only what we are ready to see, what we have been taught to see. We eliminate and ignore everything that is not a part of our practices. It's just that we can be boxed in. And with the brain, we have to get outside of our particular boxes that we're treated and ask the profound questions. Are we doing the right thing? Was our mentor correct? And can we do better? So he's a hero amongst many of us who know about him, at least, in the field of neurology. So here is our attempt to draw a collective model for the investigation, formulation, and treatment of all aspects of brain disease. This is a tree, starting at the bottom. So is the basic science, cellular, molecular neurobiology, genetics, epigenetics, as we just explained. You climb up the tree, cognitive and affective neuroscience. You climb further to the branches, look across horizontally, neuropathology, social work. Then in the red, clinical neuroscience, including rehabilitation medicine. So please, based on this trip and my experience, we welcome you. And we need to form an organization that talks amongst ourselves about that. Neuromodulation, so we talked a little bit about transmagnetic stimulation. There's cell physiology, transplants in Parkinson's disease, et cetera. So it's a brilliant time to be alive. Neuropsychology, which, by the way, I can mention that if you have a good neuropsychologist, they're the best ones post-traumatic brain injury to look at deficits, strengths, plan of intervention, and they also take instruments of measure of mood and depression, which can be remarkable variables and the central cause of some people's complaints. And then the behavioral neurology and neuropsychiatry, which I've just defined, and then on the top, neurosurgery, neurology, psychiatry, but I'm very willing in the wake of rounds this morning to put rehab medicine on the map in the top line as well. First reflection, neuroanatomy is foundational, and this is what I think makes neurology somewhat special. We actually try to observe the circuits in this, that, and the other. So just to review, basically, the neuroanatomy it represents distributed neural systems comprising anatomic regions or regional nodes, as we refer to, unique in its architectural properties, geographically arranged throughout cortical, subcortical areas, and linked anatomically in a very precise and unique manner that's predictable. And again, this is a slide from the earlier lecture by Brodmann in 1905. So it shows you the broad sweep of history, by Dr. Marcel Meselam in 2000, one of my mentors, and from more newer technology, high-tech brain function imaging. So neuroanatomy is foundational. And I hope to have proven that in the traumatic brain injury, that the areas of acceleration, deacceleration, rotational forces manifest through all of these neuropsychiatric symptoms that we need to study better, but that can be intervened with some success. Further reflections. As demonstrated by one of the opening slides, human cognition and behavior are complex and multidimensional, that philosophy matters, that Descartes' Cartesian dualism persists. Here's the mind, here's the brain, that never they should interact, but they obviously interact. So let's all agree that we have to study and be somewhat trained in each other's discipline as well. Neurologists should know a bit about psychiatry. Psychiatrists should know how to look at an MRI scan and look at anatomic regions and what might give these the TBI symptoms that we have. The third point, the shifting tectonic plates of basic and clinical neuroscience are inexorable and create a common foundation for multiple disciplines. A common foundation for multiple disciplines, rehab medicine included. Rehabilitation medicine, neuropsychology, and neuropathology should join us at the forefront of scientific advances, and I'm convinced here that that is happening. That is happening. Here's a problem. Psychiatrists read psychiatric journals. Neurologists read neurologic journals. Rehab has their own set of journals. There's no journal that joins us at this point. So we need to think about that. Not that I'm suggesting yet another journal, but I'm suggesting cross-training and cross-awareness of all of our disciplines. Contemporary and future clinicians and basic scientists will view, quote, the great divide between psychiatry and neurology as quaint, endearing, but largely irrelevant. Scientific discovery and brain science have never been more promising. The 1990s was the decade of the brain. Let's continue. And again, it's never been a more exciting time, I think, than to become involved in rehab medicine, neurology, psychiatry. And I often see people in their medical school careers saying, should I do neurology? Should I do psychiatry? And it used to be that psychiatry really had very little scientific backing, but now I think it does. So we could greet them as our equals, not as our inferiors. Psychiatry used to be called in the medicine service, neurology service, for confusional states. When I was on the neurology attendant at Mass General, here would come the neurologist, here come the psychiatrist. We talked about the patient, but we rarely talked between ourselves. And behavioral neurology, neuropsychiatry, and rehabilitation are all poised together to help drive the knowledge base upward and the outcome even better. So what do we need to do? We need to demonstrate the following benefits to sell, if you will, our approach, that it works. Does it improve clinical care? I think yes. We need longitudinal studies to prove that it's sustained. Does it enhance research? I think yes, but we need to prove that. And does it lower cost, which at least in the United States is an economic drive? I think the expense of healthcare is rising in terms of the gross national product, something like 5 to 8 to 10%. So we have to answer that question. Can it lower cost? Realities. Science and medicine do not occur in a vacuum. We live in a world which obviously sometimes dictates what medicine and science can do. Science, public health, society, ethics, morals are inseparable. We have to know that. I'm currently the honor of co-editing a volume in the Handbook of Clinical Neurology on neurophilosophy and neuroethics. So we need to push our horizons in that direction. And a quote from a professor emeritus of technology and public policy, engineering and applied science, and physics of all, at Harvard, said the following: because of the very way you do science, the very questions you ask, the methods you use, they're all embedded in things that are outside of science. Therefore, public health, society, ethics, and morals and morality are really inseparable and central to our understanding of diseases. In 2008, Dr. Judy Edersheim, pictured here, who went to law school, went into the corporate world, found out that was not her calling, doubled back, went to Harvard Medical School, and then a fellowship in forensic psychiatry, and I started an organization based at Mass General called Center for Law, Brain, and Behavior, translating neuroscience advances into law and policy. So our current initiatives are, first, protecting the elderly from fraud and undue influence in financial transactions. So this is a multi-billion dollar industry throughout the world, and who are particularly vulnerable are older adults, particularly people living alone, people widowed, people who have assets, people who may have psychiatric disorders and or cognitive disorders. My mother was such a victim, if you will, unduly influenced by factors beyond my control. The story I tell about my mother is, and she died at age 87, of about a 5 or 10 year course of Alzheimer's type dementia, is she became increasingly forgetful. I'm the youngest of 5, and we all disagreed on the diagnosis. I thought I was, fairly internationally renowned in dementia, but my 4 older siblings, you're the little brother. And so we had some discussion. Was she competent? Was she not competent? It actually came, in our case, to an autopsy-proven diagnosis. And in fact, she did have advanced Alzheimer's type dementia. She was swayed by a religious group who would come and sing songs of her denomination, and she would write the check. And I stood there and I couldn't do anything about it. So this is my fuel, my fire behind this white paper, soon to be released after some editing, called Elder Fraud Protection. Another big thing we're doing right now is a free and open access database which provides expert neuroscience resources, and this is all computer available to those involved in the judicial system, so judges, lawyers, probation officers, the incarcerated families have access to this. We had something like 3,000 or 4,000 hits, I believe, in the last 3 or 4 months. And we are able to actually get some computers into the penal system and provide up-to-date knowledge, which can be used in whatever way you want to use it, but according and hopefully in the hopes of leveling the playing field, if you will. Juvenile justice and the adolescent brain, psychological trauma, developing brain, U.S. asylum law and immigration at the border, and the role of brain science in criminal responsibility, sentencing, and rehabilitation. We think we have made modest gains in all of these at a national level and hopefully in the future at an international level. And our convictions, according to our view in the United States, the time for major criminal and probate justice reform is long overdue. Public health, law, and policy are central to healthcare outcomes. And this is where I think it's so remarkable that at this institution, the patients and their families are under no economic stress, that they come here to get excellent, excellent care. They have probably, I would think, some of the best outcomes in the world at no financial cost to them. So again, leveling the playing field to all. Better decisions aligned with science lead to better outcomes aligned with justice is kind of our banner. And the ultimate worth of science is measured by how much does it really contribute to the real world at large. So what we do a lot of things. We present neuroscience to judges, lawyers, policymakers. We do expert testimony in some cases that come to the courtroom. We try to debunk old myths about mental and cognitive states. One of the dementia myths is that dementia patients can have periods of lucidity during which they sign a document. That's just not true. Dementia is dementia, and never do you rise to the level of sheer competence when it comes to complex decision making. That we also work across media, because media is a big deal, right? Social media, to inform the public about the brain, behavior, justice. And our efforts, we believe, have led to more just neuroscience outcomes, as well as more enlightened perspectives in which advanced legislative reforms, trial outcomes of state, national, and international levels are occurring. So we feel very proud of this. A small budget, but for that budget, we do a lot, we believe. Challenges and controversies. Some of us, I think, biologically reduce people and ignore kind of the multiple levels of complexity that I just outlined in the traumatic brain injury. I think some of us can be dangerously oversimplify situations. I think science, at least in the minds of many people in my country, I think that it should conquer all diseases. And some people overpromise that, and I think that's a mistake. And in many cases, again, when I'm the neurology attending at Mass General or at McLean Hospital, never forget that social determinants remain the primary driver in many illnesses. Neurology residents tend to be molecular in their orientation and forget about the external comments. There was one young kid that was diagnosed with attention deficit disorder until they found out that he and his mother lived in poverty in a car. So the root cause analysis was deal with the poverty. And in fact, once he got over the depression, the anxiety, where's my next meal coming from, he turned out to be quite normal in his attention span. Strengths, I think, remain the physician-patient relationship, which hopefully was demonstrated this morning during rounds, and the emerging neuroscience of integrated and transdiagnostic psychiatric, neurologic, rehabilitation domains and interventions. The requirements for this, similar to the TBI argument, is we must foster international collaborative research, translate it to clinical practice across disciplines, across countries, across faiths. We need to emphasize prevention. Neurology should become a preventive approach to brain health care, early diagnosis, intervention, and recovery. TBI, as we said, needs to be recovered. We need to train the best and the brightest of the clinician scientists that come up through medical school or graduate programs and recruit them into this, get them involved in research, which I understand is done really very nicely at the humanitarian city here. We have to convince the public. So we have a public relations problem about the positive impact of science and the here and why of what we do. Unfortunately, what we're witnessing in the United States is an attack at the highest levels on science and the reduction of such things as preventive vaccines. It's a shame. I am named after my maternal uncle who died in the 1940s at the age of 8 of diphtheria. That's an entirely preventable disease. And as I will mention, it looks like, ironically, in this light, that shingles vaccine, flu shot, tetanus, diphtheria, might have preventive reduction of dementia risk. So all of this is tied into this complexity of brain-body interactions. And we have to address the stigma and challenge old beliefs and welcome new science, particularly in our country when it comes to psychiatry. You must be crazy. Well, there's a biologic cause usually and a stress cause that we can address and actually turn the corner and make the patient much, much better. And we need to translate neuroscience into social impact, addressing intersecting legal, ethical, philosophic, policy issues, which is what our Center for Law, Brain, and Behavior attempts to do. Core questions. How can we preserve our holistic humanitarian approach in medicine? How can we break the chains of tradition and move forward together? And again, how do we recruit more of the best and brightest to our disciplines and promote cross-training? And this can certainly be, I would love to hear opinions on how we accomplish these rather major goals. Lessons I've learned is don't stay in your lane. Now, in academic medicine, in my experience, stay in your lane. It's where you get promoted. Don't veer. Don't cause controversy. Just drive through this narrow passageway we call a promotion. What I'm saying is, as a neurologist, I shouldn't stay in my lane. I should learn some psychiatry. Rehab medicine needs to know about neurology, recovery, psychiatry. We need to assume a more consequential role. We need a higher public voice in these related issues. Who will be the next generation of powerful voices translating science and medicine to the public? In the United States, this goes back and dates me a bit, but there was an astronomer that came on TV shows named Carl Sagan, who promoted science as a way to understanding human behavior. And he predicts, this is always a fascinating discussion to me, is that there must be life on other planets. And who are they, and can we learn? Oliver Sacks was a neurologist who wrote and communicated incredibly well with the public. He's the one that showed the early trials of L-DOPA in Parkinson's disease and how after this disease called encephalitis lethargica, they would at least become normalized slightly, and then descend back into their state. But L-DOPA made a huge difference transiently, so it gave kind of rise to the further science that said L-DOPA is a deficiency, is a treatment, somewhat effective, at least symptomatically, for Parkinson's disease. I think if we're really going to join together, we need open source, data sharing, and accessible science that we share together, not in competition, but we rise together, all boats. And that artificial intelligence, and you can't give a lecture now today without mentioning AI, can be a major advance depending on who owns it, their intended purposes, and there are significant concerns as well. AI can be misused. AI can be used for surveillance purposes with goals that I think are questionable. But AI needs to be addressed, and we need to be in the forefront of what are the perils, what are the concerns, and what are the promises of this complex, enigmatic field that's just now developing. And then, now, if any of you are a science fiction reader, and I think he's been translated in multiple languages, a fellow named Isaac Asimov, who wrote over 500 books, hundreds of short stories covering science fiction, popular science, history, and more. I think he was affiliated with Massachusetts Institute of Technology. And he says, science gathers knowledge faster than society gathers wisdom. Sometimes science is so advanced and we have to catch up with philosophy, morality, ethics, faith-based beliefs. So therefore we need the philosophy, the morality, the ethics, and faith to advance our wisdom base. And again, I've tried to provoke you. I've tried to make you uncomfortable. You're invited to make me uncomfortable. But these are provocative thoughts from a think tank into a thought engine. And again, ending with the picture of me, mind your head, and thank you for your attention.
Thank you, Professor Price, for this very interesting lecture. We can take one or two questions because we are run out of time. Dr. Abdul Malik, I think this lecture provoked a lot of sadness for psychiatrists.
My name is Dr. Yusuf Abdul Malik. I'm a consultant psychiatrist. So my question is about, according to my experience here in our hospital, many patients with traumatic brain injury, they develop disinhibition, particularly sexual disinhibition. Now, I would like to hear your experience about managing such cases. Some will give, mood stabilizers such as lamotrigine or Tegretol, or even sometimes they give neuroleptics. So I would like to hear your experience, because this can create some sort of management difficulties.
May I hear your experience first? What is your experience with the post-traumatic brain injury, sexually, socially inappropriate behaviors? Any way to ameliorate that problem in your field?
Well, mostly I use mood stabilizer. Particularly, I'm preferring such something like lamotrigine or Tegretol, and I found them helpful to some extent. I would say. Still they create some sort of management difficulty.
Right. And I know this most in the dementia population. So at the hospital I work at, which is the primary psychiatric hospital of Harvard Medical School, is a dementia ward, maybe at any given moment, 12 to 20 patients. And there's an interesting rule that most of them tend to come in on Friday evenings. Why? Because that's when the family has finally reached their threshold. and they're so inappropriate and so unlike themselves, and they have no control, nor does the family. They come to the emergency room, they get admitted to the inpatient ward for hopefully transient help. I think the ones that are sexually explicit, screamers, aggressive people, it's incredibly hard to, I just don't think that that responds to the medicine. You can medicalize them, psychopharmacology, into a state of inertia, but it's hard to really, particularly if they're delusional around sexual themes or other social themes. You can't just, in dementia, what you teach is you try to distract them from the issue. So you take them back to a nice family gathering with a photo. If they are inappropriate, demented, agitated, and sexually aggressive, that's incredibly hard, and that's disruptive to the entire ward. But we have to hospitalize them because they're disruptive to the entire family. The family's exhausted. Where else do you place them? And yes, we use the usual neuroleptics to kind of calm them down. I think you can do, in the past they've done kind of hormone therapy. I don't think that's been of great benefit. So you just try to use kind of redirect them, calm them. Music may help. Maybe if the family gives them support and tries to understand what's going on, that can help. But I think it is one of the most difficult problems that we face in dementia care and agitation without really any fundamental answers. Is that your experience too?
Yes.
And you try medicines, of course, and sometimes they work.
Yeah, actually, it's
And speak into the mic so I can,
the role
yeah,
of,
hear you.
psychology is very important.
Yeah, yeah.
Particularly the family role is quite important in such cases.
Right.
But actually, my question is regarding the pharmacological
Yeah.
treatment.
Do we have a mic? Can we? You have the microphone?
His question
I want to hear you better. Yeah.
Pharmacological
Yeah.
effect of antidepressant in post-traumatic brain injury patient with sexual dysfunction.
The role of psychology is very important
Yes.
in such cases, particularly, the family role is quite important, and that can be understandable, of course, and that's part of the management, because it's multidisciplinary team work in such case. But really, my question is about the pharmacological treatment in particular.
Yeah.
So I want to hear your experience in using any sort of mood stabilizer or any other treatment.
I know there have been trials of hormonal manipulation. I don't think they provide a fundamental answer. I would agree until we discover something different. Thank you. That the psychosocial, the training of the family to calm, to redirect, to not be offended, and that this is the disease speaking, this is not their mother, this is not their father, it's not who they are, but it's in the context of dementia in my particular experience. So psychological means to redirect, to calm, and maybe with some medications I think may help. The carbamazepines, the valproates of the world may take the edge off, but no more than that. And it's a difficult problem once when they come to a psychiatric ward, and then the deposition. What do you do with them, particularly if they're still inappropriate? Do you send them home? Probably not. In the States, we have facilities. They're not like this. And so it's one of the most challenging problems in neuropsychiatry that I know. So if you find something better, would you please contact me, and we're happy to run the trial.
Last question, please.
At first, here, Dr. Bruce.
Okay. Got it.
So at first, I would like to thank you for this informative presentation. You mentioned in the first part of the lecture is polypharmacy. And you mentioned that the best thing that you can recommend for a patient is reducing the number of medications that the patient have. But in TBI, there are symptoms that cannot be managed except for with medications. So from your experience, what is the best practices that helped manage the symptoms without the medication?
And what symptoms again are you referring to?
Overall symptoms.
Overall symptoms in post-traumatic patient, you mentioned that during the round you did with Dr. Ines, there's a lot of polymedicated patients. And with all the side effects of this medication, what is your advice to reduce the dependence on this medications by other ways of treatment, non-pharmacological?
So let me give you a case, if I will. At McLean Hospital, again, the major primary psychiatric hospital, the Harvard system, we often see people with catatonia, and people understand that in the psychiatric world. And so we do have some effective treatments. You can start with a benzodiazepine. Usually we start with an IV, so maybe something Ativan, short acting. If that doesn't break the catatonic state, then you can go to electroconvulsive therapy. But then there's the lingering 20%. And by the way, in catatonia of interest, about 20% of those are medical and neurologic in origin. Parasagittal, falcine meningiomas, complex partial seizures, diabetic ketoacidosis. So not everything is psychiatric or neurologic. It can be medical as well. So you have to discover that. But then there's that outlined 20%, and we get consulted on that. What can we do next? And it's a very, very difficult problem. I'm on what's called the Psychiatric Neurosurgery Committee at Massachusetts General Hospital. We can try to implant deep brain stimulation. This, that, and the other.
For OCD, for example.
OCD, yeah, and that's where we have the best proof, by the way. It sounds barbarian, if you will, and they used to burn holes and do lobotomies and so forth.
It's better than the ECT in the past.
Right, yes, and ECT has its problems as well.
Yes.
So again, to me, it's an example of neurology, psychiatry are complex. You have to be very diligent. You have to follow over time. And again, time is a friend in many ways, because in neurology, in certain diseases, they play out over time and they identify themselves later on. But I don't think I'm quite answering your question, so make me focus. How can you state the problem? Again, the question, if you will. And with the mic, yeah, oh, I see.
So the problem we are facing in rehab, because I'm an occupational therapist, so the symptoms sometimes cannot be managed except for the medications, and sometimes can be a lot for the patient.
Yeah.
So yeah, I'm not sure if it's the answer that you answered, but the practices or the approaches that we can follow as a team, a hollow team, to manage these symptoms without the medications.
Psychoanalysis, for example.
You should, try.
Psychoanalysis, for example, can help in such cases. Behavioral treatment can help in such cases. It's disciplinary management for the symptoms. Sometimes patients with post-traumatic injuries, they have behavioral changes. Either it's related to seizures, either it's related to psychiatric issues because the lesions are localized in frontal or in temporal areas, which are highly or full of functions, psychological functions like frontal lobe and the temporal lobe. Second, the third thing is the side effect of the medication. For this reason, if you noticed in the presentation of Professor Price, he said that the usage of benzodiazepine and antipsychotic treatment should be preserved for very limited cases. And this is very important in the management of behavioral disorder related to post-traumatic brain injuries.
Yeah, thank you.
And this is where neurology meets psychiatry, and there should actually be active dialogue between the two. And many institutions in the States, here's psychiatry, here's neurology, and there's no bridge. And that's what one of my academic missions
I
has
see
been, is
Dr.
to build a
Abdul Malik
bridge.
once a week.
What's that?
I see him once a week. Abdul Malik.
See, there you go, leading the model once
But we
again.
have a lot of referrals for each other.
Oh, good.
Rule out seizure, rule out psychosis.
Yeah.
I think in the future, maybe we will see, as now we know that psychiatric disease are receptors disease, yani serotonin, dopamine, all these things. I think in the future, so it's a brain disease.
Yeah.
Psychiatric disease
sometimes
is a brain
there is
disease.
a lot
So
of
maybe
debate.
psychiatry will be in the future a subspecialty of neurology.
Those are fighting words.
Sometimes there is a lot of debate who should treat such case. For example, dementia cases, particularly when it comes to vascular dementia, traumatic brain dementia. Who's supposed to treat such cases?
Yeah.
Neurologists,
Yeah.
mainly, but maybe psychiatrists.
It's a gray zone.
Yeah.
It's a gray zone
Yeah.
between two specialties.
Yeah,
Right.
I mean, Alzheimer's disease, for example, can be treated by both neurologist or psychiatrist.
So I also have the privilege that you share, which is I talk a lot to psychiatrists. I teach a lot of psychiatry residents and fellows, and so we cross-communicate. And to me, that's a joy.
We divided the brain into two, the right hemisphere, the emotional for Dr. Abdul Malik, and the thinker left
Right down
hemisphere
the middle.
for me. So it might be like this. Okay.
Take both of them if you want.
Yeah. So thank you for inviting me. Praise be to Prince Sultan.
Thank
Praise
you.
be to
Thank you.
all of you.
Thank you, Professor
This is a
Price.
remarkable institution, and therefore praise be to Abdullah bin Zahar. He's running a really amazing enterprise. So thank you and congratulations.
Thank you very much for this very nice afternoon activity. I would like to ask our CEO, Mr. Abdullah bin Zara, to come and present appreciation certificate for Professor Price.
You want to be in the middle?
You will be.
Okay.
Appreciate your efforts. Thank you so much. It's been a pleasure.
Great, thank you.
Appreciate it.
Yes, thank you for all that. Yeah.
It's a pleasure.
Are you, Dr. Lena Serhal, do you know her? No, she helps take care of some of the patients.
What's her name?
Lena Serhal, S-E-R-H-A-L. She's a primary care doctor
No, where is she based?
here in Riyadh, but she takes care of some of the,
I see.
yeah. So I just wanted to make sure that, because I wanted to see a patient or two with her, so maybe what I'll do is I will call her
Okay, yeah.
and create the time.
We'll find a way to
Okay.
fit her into the schedule.
Okay.
I will coordinate.
Various things coming out of my pocket. This is not the microphone.
Thank you, Doctor.
So in conclusion, we would like to sincerely thank our distinguished speaker, Dr. Bruce, for sharing his valuable knowledge and insight with us today. Also, we would like to thank Dr. Ayman Qassas for moderating this session and extend our appreciation to all attendees, knowing that we have more than 65 staff joining us through our Teams channel. We would like to invite everyone to join us for tomorrow's virtual session at 2 p.m. titled Successful Aging. Thank you all for attending and have a wonderful rest of the day. Thank you.